discuss the next session from pathology for MRCS Part B, and that is gangrene and mesothelioma. Okay, so first we will discuss the gangrene. So what is gangrene? So gangrene is basically the type of necrosis. Okay, it is a type of necrosis which is caused by critically insufficient blood supply. Okay, so gangrene is a necrosis, type of necrosis which is due to ischemia or insufficient blood supply. Okay, so now we will discuss or define the necrosis. So necrosis is a accidental or unregulated form of cell death, okay, resulting from damage to the cell membranes and loss of iron homeostasis. So necrosis is pathological form of the cell death. Okay, the other form of cell death is apoptosis, which is physiological. Okay, and the apoptosis occurs without any signs and symptoms of inflammation, while the necrosis always occurs with inflammatory reaction. Okay, so that's the cell death. So types of cell death can be necrosis or apoptosis. Okay, so necrosis and apoptosis. So now we will discuss the difference between necrosis and apoptosis. First, about the cell size. The cell size become enlarged in necrosis, while it become shrink or reduce in the apoptosis. Okay, then about the nucleus. In the necrosis, the nucleus undergoes several processes like karyopyknosis. Then after karyopyknosis there will be karyorexis, and the last stage is karyolysis, which means the breakdown of nucleus. Okay, but in apoptosis there is fragmentation of the nucleus into nucleosome size fragments. Then about the plasma membrane. The plasma membrane becomes disrupted or damaged. Okay, so the plasma membrane in nucleus is damaged, while in the apoptosis the plasma membrane is intact, but it has altered structure, especially orientation of lipids. Then about the cellular contents. The cellular contents undergo enzymatic digestion, and it may leak out of the cell. Okay, because the cell membrane is broken down. So when there is cell membrane broken down, damaged cell membrane, then the cellular contents leak out of the cell. But in the apoptosis the cellular contents or components are intact, and it may be released in apoptotic bodies. Okay, as I mentioned before that there is always adjacent inflammation in the necrosis, but there is no inflammatory reaction in the apoptosis. Okay, no inflammatory reaction. Okay, so the necrosis is pathological. Okay, while the apoptosis is often physiological. Okay, so these are the differences between the necrosis and apoptosis. Okay, now we will pathogenesis. We will discuss about the pathogenesis of necrosis. So in the pathogenesis, okay, there is first step in the pathogenesis is severe and prolonged ischemia, which can lead to severe swelling of the mitochondria and other organelles. Then there is calcium influx into the mitochondria and into the cell with the rupture of lysosomes and plasma membranes. Okay, so the death by the necrosis is due to release of cytochrome C from the mitochondria. Okay, so this diagram showing the steps in the necrosis, this is Okay, so this is necrosis and that one is apoptosis. This is normal cell with the nucleus and all the organelles. Okay, but due to ischemia, okay, due to prolonged or severe ischemia, there is swelling of the organelles like endoplasmic reticulum and mitochondria, and the calcium influx occur in these organelles. Okay, membrane blebs also formed, myelin figure also formed. Then after that, there is breakdown of plasma membrane and organelles, and there are leakage of contents. Okay, so the contents, the cellular contents leak out of the cell, and due to breakdown of plasma membrane. Okay, so this is myelin, and as the cellular contents leak out, it causes the inflammatory cells to travel at the site of the necrosis. Okay, so these are that inflammatory cells. So the necrosis is always accompanied with the inflammation, but in the apoptosis, the first there is condensation of chromatin and membrane blebs are formed. Then the cellular fragmentation occurs into apoptotic bodies. Okay, so apoptotic bodies are formed, and then these apoptotic bodies are phagocytosed by the phagocyte cells. Okay, so there is no inflammation in the apoptosis, so no inflammation in the apoptosis, but in the necrosis there is inflammatory reaction. Okay, so there is inflammation. Okay, this question, the post gangrene patient, why there is redness? Okay, so there is redness due to post hypoxic vasodilation. Okay, now we will discuss about the dry differences between the dry and wet gangrene. Okay, so dry gangrene most commonly occurs in limbs, okay, while the wet gangrene occurs most commonly in bowel. The mechanism involving in the dry gangrene is arterial occlusion, while in the wet gangrene there is venous obstruction. Okay, in the dry gangrene the organ is dry, shrunken and black, while in the wet gangrene the organ is moist, okay, soft, swollen, rotten and dark. In the dry gangrene there is limited putrefaction. Okay, putrefaction is limited due to very little blood supply, while in the wet gangrene there is marked putrefaction due to stuffing of organ with blood. Then the line of demarcation, it is present at the junction between the healthy and gangrenous part in the dry gangrene, while there is no clear line of demarcation in the wet gangrene. Bacteria will be absent in the dry gangrene, while in the wet gangrene there are numerous bacteria present. The prognosis of the dry gangrene is better due to little septicemia, while in the wet gangrene the prognosis is poor due to profound toxemia. Okay, so these are the differences between the wet and dry gangrene. So in the necrosis or in the gangrene, what is the cause of ischemia? So the cause of ischemia is atherosclerosis. Now what is atherosclerosis? It is pathological process of the vasculature in which an artery wall thickens as a result of accumulation of fatty material such as cholesterol. Risk factors of atherosclerosis include smoking, hypertension, diabetes, family history, increase LDL. Okay, increase LDL, while the HDL is protective. Okay, then the pathological process cells of atheroma are macrophages, okay, macrophages and lymphocytes. Now the patient developed cough, one bedside test to do. So the one bedside will be sputum analysis, and if the X-ray show pleural plaques, then what will it signify? So the pleural plaques is the most common manifestation of the asbestos exposure, and they are well circumscribed plaques of dense collagen that are often calcified. Okay, so pleural plaques are due to asbestos exposure, and they are well circumscribed plaques of dense collagen that are often calcified, and its significance is that it increases malignancy risk of mesothelioma, okay, and bronchogenic carcinoma. Now the question is, give one classification of the lung cancer. Okay, so this is the classification. The first type of cancer is non-small cell lung carcinoma, while the second is small cell lung carcinoma. Okay, so this is second one. Now about the non-small cell carcinoma, these share common features of prognosis and management. Paraneoplastic features and early disease dissemination are less likely than with small cell carcinoma. They comprise the following tumors: adenocarcinoma, 40% cases, most common lung cancer, which is encountered in never smokers people. Okay, then the small cell carcinoma of the non-small cell lung carcinoma, it is present in 25% of cases. It is more slow growing and are typically centrally located. Then the large cell carcinoma is 10% cases. Okay, then toward the small cell lung carcinoma, the small cell lung carcinomas are comprised of cells with neuroendocrine differentiation. The neuroendocrine hormone may be released from these cells with a wide range of paraneoplastic association. These tumors are strongly associated with smoking and will typically arise in a larger airways. They disseminate early in the course of the disease, and although they are usually chemosensitive, this seldom result in long lasting remissions. Okay, so this is about the small cell lung carcinoma. Now the patient is present with mets poorly differentiated. How to tell its epithelial origin? So to know about the epithelium, we will do immunohistochemistry. Okay, immunohistochemistry or fish technique. Okay, fish technique and immunohistochemistry. Then if the tumor was epidermal growth factor positive, what will be the chemotherapeutic agent? Okay, so we will use the tyrosine kinase inhibitor. This is imatinib. Then the type of necrosis, the necrosis can be coagulative, liquefactive, caseous, fatty, fibrinide, and gangrenous necrosis. Okay, now we will discuss about the lung cancers. Lung cancer, what other lung cancer do you know? Okay, so the lung cancer can be of small cell lung carcinoma, we have already discussed, and it can be non-small cell lung carcinoma. Okay, small cell and non-small cell. Non-small cell carcinoma can be adeno, squamous, and large cell carcinoma. The best prognosis is of squamous, after squamous the large cell carcinoma, then adenocarcinoma, and the small cell carcinoma has a bad prognosis. Okay, so what are the sign of aggressiveness on the report? Okay, so this is the report. You can see the 70-year-old male smoker COPD with small cell lung carcinoma. Histology report saying carcinoid invading pleura and lymph nodes. So invading pleura and lymph nodes involved shows the sign of aggressiveness. Okay, then pathogenesis of clubbing. So various hypotheses have been proposed over the years to explain the pathophysiology of the digital clubbing. So the digital clubbing mechanism is not known, but there are some theories which is about the mechanism of digital clubbing. So let's look into it. So the first, some research found significantly higher plasma growth hormone level in patients with lung carcinoma and clubbing than the patients without clubbing. Okay, so this is one of the theory, and the second theory is that the megakaryocytes are platelets clusters lodge in the peripheral vasculature of the digits, release platelet platelet derived growth factor PDGF. Okay, PDGF due to increased vascularity, permeability, and connective tissue changes that are the hallmark of clubbing. Okay, then Pancoast paraneoplastic syndrome. What hormone? So in the Pancoast paraneoplastic syndrome, the hormone is ACTH, which causes the Cushing syndrome. Now the patient present with the METs poorly differentiated how to tell its epithelial origin. So immunohistochemistry or FISH technique can be used to know about epithelial origin. Then what is FISH technique? It is fluorescence in situ hybridization. It is a kind of cytogenetic technique which uses fluorescent probes. Okay, so it uses fluorescent probes binding parts of the chromosome that show a high degree of sequence complementarity. Fluorescence microscopy can be used to find out the fluorescent probe bound to the chromosome. Okay, so this is about the FISH technique. If the tumor was epidermal growth factor positive, what will be the chemotherapeutic agent? So we will use tyrosine kinase inhibitors in the tumor with epidermal growth factor positive, and that is imatinib. 6 months later he came with back pain. Why? So due to bone mets. What other tumor has metastasis to the bone? So breast cancer, lung cancer, okay, the thyroid cancer, prostate cancer, and multiple myeloma. Okay, so this is these are the carcinoma which travels or which spread to the bones: breast, lung, thyroid, kidney, prostate, and multiple myeloma. Okay, now this question, define adenocarcinoma. So adenocarcinoma is a cancer that forms in a mucus secreting glands throughout the body. Okay, define emphysema. Emphysema is a lung condition that causes shortness of breath. In people with emphysema, the air sacs in the lungs alveoli are damaged. Over time, the inner wall of the air sacs weaken and rupture, creating large air spaces instead of many small ones. Now define paraneoplastic syndrome and give examples. So the paraneoplastic syndrome is symptom complexes that occur in patients with cancer and that cannot be readily explained by local or distant spread of the tumor or by the elaboration of the hormone indigenous to the tissue of origin of the tumor, are referred to as paraneoplastic syndrome. Examples are ACTH secreting tumor, hypercalcemia, SIADH. So we will discuss about the paraneoplastic syndrome in details. Okay, so the paraneoplastic syndrome, the first is Cushing syndrome. Okay, Cushing syndrome, and it release the ACTH or ACTH like substances, and the neoplasia which has paraneoplastic syndrome of Cushing syndrome is small cell carcinoma of the lung, pancreatic carcinoma, and neural tumors. So these are the tumors which is associated with the paraneoplastic syndrome, which secrete the ACTH or ACTH like substance. Then the second is SIADH, syndrome of inappropriate antidiuretic hormone. So the neoplasm which are associated with this syndrome is small cell carcinoma of lung and intracranial neoplasm, and it secretes the antidiuretic hormone, okay, or atrial natriuretic peptide. Then the third is hypercalcemia. Okay, so the neoplasm associated with this condition is squamous cell carcinoma of the lung, okay, squamous cell carcinoma, breast carcinoma, renal carcinoma, and adult T cell leukemia. And the hormone which is secreted is parathyroid hormone related protein. Okay. Then the fourth one is hypoglycemia. The carcinoma associated with it is fibrosarcoma, other mesenchymal sarcomas, ovarian carcinoma, and it releases insulin or insulin like substance. Then the fifth one is polycythemia. It occurs in renal carcinoma, cerebellar hemangioma, and hepatocellular carcinoma. And the agent which is produced by the polycythemia is erythropoietin. Okay. Then the nerve and muscle syndrome. These are two. First is myasthenia gravis. It is associated with bronchogenic carcinoma and thymoma. And the mechanism involved in myasthenia gravis is immunological mechanism. Then the disorders of the central and the peripheral nervous system. It is associated with breast carcinoma and teratoma, and the mechanism is immunological mechanism. Then the dermatological disorder is which is paraneoplastic is acanthosis nigricans and dermatomyositis. Okay, so acanthosis nigricans occur are associated with gastric carcinoma, lung carcinoma, and uterine carcinoma, and it is immunological in mechanism, and it secretes the epidermal growth factor. Then the dermatomyositis is associated with bronchogenic carcinoma and breast carcinoma, and mechanism involved is immunological mechanism. Then the osseous, articular, and soft tissue changes. So the hypertrophic osteoarthropathy and clubbing of the fingers. Okay, clubbing of the fingers and hypertrophic osteoarthropathy is associated with bronchogenic carcinoma of the lung, and the mechanism is not known. Then the vascular and hematological changes like venous thrombosis, Trosu phenomena. Okay, and the non-bacterial thrombotic endocarditis and anemia. So the venous thrombosis or Trosu phenomena is associated with pancreatic carcinoma, bronchogenic, and other cancer. And the mechanism or the agent which involved in this is tumor products, mucins that activate the clotting. Okay, then the non-bacterial thrombotic endocarditis is associated with advanced cancers, and the mechanism in this is hypercoagulability. Then the anemia is associated with thymoma, and the mechanism is immunological mechanism. Then the nephrotic syndromes occurs in associated with various cancers, and the agent which is involved is tumor antigens and immune complexes. Okay, so this is about the paraneoplastic syndrome. So in the adenocarcinoma, the paraneoplastic syndrome will be clubbing, hypertrophic pulmonary osteoarthropathy, and Trousseau syndrome or venous thrombosis. In the squamous cell carcinoma, there is hypercalcemia of malignancy due to PTH, parathyroid hormone related protein, and the Pankos syndrome, which causes the ACTH or the Cushing syndrome. Then the small oat cell carcinoma is associated with syndrome of inappropriate ADH, Lambert-Eaton myasthenic syndrome, and cerebellar degeneration. Okay, so this is all about the paraneoplastic syndrome. So we cover the gangrene, the lung cancer, mesothelioma. This is all about today's lecture. Thank you.